varied, and so it's a complicated thing to approach. And unfortunately, visual outcomes typically still remain quite poor due to the challenging nature of the condition. So we're all familiar, or we should all be familiar with the normal drainage pathways in the eye. The thing to be aware of is that in children, particularly in infants or neonates, the angle anatomy is not necessarily what you see in the textbook. It's still developing. And so it's important to keep that in mind, particularly when assessing children with glaucoma. Pediatric glaucoma is often associated with a dysgenesis of the angle. And so appreciating how normal angle anatomy develops is important in working out, are you dealing with a primary congenital glaucoma, for example? So if we think about how the anterior segment develops in the baby, the first elements of the anterior chamber begin around about 5 weeks of gestation, so quite early. And it starts basically from a combination of surface ectoderm as well as mesenchymal tissue, including neural crest tissue. By about 7 weeks, you've got a rudimentary anterior chamber that's forming, and a pupillary membrane and the posterior aspect of that. And that's typically, it's an endothelial lined chamber. By about 7 months, you're having an element of trabecular meshwork developing, as well as more obvious iris and pupillary membrane. When we look at that in a bit more detail, we can see that the trabecular meshwork actually forms behind the rudimentary iris, and by 20 weeks of gestation, it still hasn't cleaved away from the iris, and it actually sits behind an iris membrane. By the third trimester, you're seeing posterior migration of the iris so that the trabecular meshwork becomes more exposed. That endothelial lining around the iris and the cornea and anterior chamber is starting to fragment and develop cavitations, and you see pupillary membrane formation across. By the time children become term, you see most of the structures of the anterior chamber are formed. The thing to note is you often have quite an anteriorly positioned trabecular iris, up to the trabecular meshwork, and it isn't until you're about a year old that iris insertion tends to migrate posteriorly. In primary congenital glaucoma, you see an arrest of that normal anterior segment development that then contributes to angle closure of primary congenital glaucoma. So the current consensus in terms of childhood glaucoma classification, we go by the WGA consensus series, and we think about glaucoma basically as a primary congenital glaucoma, which either includes, primary childhood glaucoma, which either is primary congenital glaucoma, so that's glaucoma that's present within the first 2 years of life, and then we subcategorize that as neonatal versus infantile versus late onset. And then there's juvenile open angle glaucoma to encompass those primary glaucomas in the younger population who are older than about 2 years. And then there's the whole pile of secondary childhood glaucomas, and we can think of that as those that involve non-acquired ocular anomalies, and that's predominantly the anterior segment dysgenesis type conditions, as well as some others. Those associated with acquired conditions, of which uveitis, trauma, and steroid-induced would probably be the most common, and then we have tumors and retinopathy of prematurity and post-surgery can contribute too. There's also a larger group of those acquired, non-acquired systemic diseases or syndromes that we know contribute to glaucoma, of which there's numerous. And then a larger group of kids we often see in the clinic with glaucoma are those following congenital childhood cataract surgery. And then those can be classified depending on the type of cataract they had. So as Amani correctly pointed out, there's a typical triad of symptoms that children present with in classic glaucoma, congenital glaucoma, and that's the cloudy cornea, with an enlarged eye and a watery eye. Children may also be a bit photophobic and irritable. And certainly there are other conditions which can sometimes present with a watery eye. For example, nasolacrimal duct obstruction would be one of those. So, and children may not present with the typical presentation. So it's important to be aware and certainly suspicious of any child that you see who has any of these types of symptoms, to be always thinking about glaucoma and the first of your list to exclude when you see them. If you're concerned about glaucoma, then the first step we need to think about is taking a history. An important part of the history would be looking at when the symptoms began, because that tells us a bit about what their prognosis is going to be in terms of vision, and a bit about what the likely underlying condition would be. A gestational history is very important in all pediatric conditions, and certainly the presence of any intrauterine infections would be very important, of which rubella would be the most important intrauterine infectious cause of glaucoma. Also, the method of delivery. That's certainly important in terms of thinking about differential diagnoses of a cloudy cornea, for example, in a forceps-induced corneal trauma. Family history is very important in pediatric glaucoma, so asking about parent any history of children in the family who may have glaucoma. Also, it's important to ask about family history in terms of any consanguineous relationship, because a lot of congenital glaucoma is related to recessive genes, in which case much more likely in a consanguineous relationship. Has there been any previous history of trauma or cataract surgery or previous surgery? Is there any general medical issues that we need to be aware of? Is the child neurologically normal? Are they a bit delayed? Do they have any other cardiac or genitourinary abnormalities? A lot of these conditions can be associated with syndromic causes of glaucoma as well. And certainly, with any child, you need to be thinking about any anesthetic or airway issues that might be important, because most of these children will be thinking about needing an EUA under anesthetic. Previous history of any use of medications, and particular attention to any steroid-related medications, particularly in older children, for example, with atopy. So once we've taken a history, then what do we do? Well, the goal is to essentially try and establish a diagnosis, or trying to get in your mind if this is most likely to be a congenital glaucoma or an infantile glaucoma in the office. Certainly you can get a lot out of children from an office exam, but it is a bit limited, and it obviously depends on the compliance of the child and the available equipment that you have. But often you can certainly get a measure of their vision. Is it reduced in the clinic? We have available to most of us eye care tonometry, which has allowed us to measure intraocular pressure in the clinic much more easily than we could on infants in the past. But we have to be aware of the caveats of the certainly the accuracy in eye care tonometry, but it can be useful if it's normal. And we can, if we have available to a supportable slit lamp, and even at the slit lamp, you can sometimes get babies at the slit lamp in the clinic. If you can get a slit lamp examination, it's very important to be able to assess the cornea in particular, as well as looking at iris and being able to assess the lenses is important. Gonioscopy is probably only realistically possible in the office setting in older children, but it's a really important part of congenital or childhood glaucoma workup. So it needs to be performed at some point, and if you're not able to do it in the office, then really it needs to be done as an under anesthetic. It's always important to be able to perform a dilated fundoscopic exam, looking for optic nerve cupping and any other structural abnormalities. Cycloplegic retinoscopy is often important in any pediatric assessment, and certainly working out if this child is emmetropic versus myopic lets us have a bit more suspicion if this is glaucoma. If in older children, you may be able to get an axial length measurement, and sometimes in babies with some topical anesthesia, you can do a scan, ultrasound axial length, and that can be useful as well in assessing glaucoma. And it's really important in any pediatric condition with a heritable component that we examine parents and siblings to look for any signs of glaucoma or any other contributing conditions such as anterior segment dysgenesis, which can sometimes be dominantly inherited. but not necessarily present. Parents may not be aware they have the condition. The classic sign that we see in congenital glaucoma is ophthalmos. It's a term that's come from the Greek word bous, meaning ox or cow, and obviously related to the appearance of the eye that resembles that of a cow. And it's an eye that has an increased corneal diameter, increased axial length, and overall that contributes to the eye becoming quite myopic. It's useful to have in your mind what is a normal corneal diameter, when particularly for more subtle cases of glaucoma where you're not quite sure is this normal or not. Certainly a newborn child with a corneal diameter of more than about 11 millimeters is likely to be abnormal. And a year about 12 millimeters, and any eye that's greater than 13 millimeters, that is abnormally large cornea. And similarly with axial length, we know that newborns have relatively short eyes, and that increases over time. And anything outside of the normal range in axial length or outside of the normal range and change in axial length should raise suspicion of glaucoma being underlying cause. These numbers are obviously a guide and shouldn't be used as a prescriptive cutoff for diagnosis, but certainly help to add to the picture. And obviously any child who's myopic is abnormal. Most children who are born should be a little bit hyperopic, and myopia is an unusual finding. So the clinical signs to look for in the cornea, we'll just go through them in sequence. Now, increased corneal diameter we've discussed. Corneal clouding can be quite diffuse, or it might be in a small patch, and it's often related to small tears in Descemet's membrane with rapid expansion of the eye. And they present later on once the clouding has settled as little horizontal or sometimes vertical lines within the posterior aspect of the cornea. They're basically rolls of Descemet's membrane called Harb's striae, and that's pathognomonic of congenital or childhood glaucoma. As we talked about, the iridocorneal angle in glaucoma is abnormal in children. Sometimes it's difficult to completely exclude an abnormal angle from I guess, an immature angle in newborn babies. They all look a little bit unusual. But the things we're looking for is a fairly flat, anteriorly positioned iris that inserts into the trabecular meshwork, and an indistinct appearance to the trabecular meshwork, which is almost like a membrane across it, which has been coined Barkin's membrane. It's not necessarily a membrane there, but it just looks like that. And prominent iris processes can be a part of the picture as well. Now, gonioscopy you can often we need to perform as part of an EUA in children. And obviously cupping is a very universal sign of glaucoma, and we should be looking for that in the kids, particularly asymmetry in optic nerve head cupping in unilateral cases can be quite telling. Often there's significant corneal clouding. You may not get a good view of the optic nerve, but you can sometimes get a good a suggestion of cupping on B-scan ultrasound, and that's where you look for this sort of bean pot sign and the posterior on the optic nerve. You can see in the posterior aspect of the globe there on this B-scan. So B-scan ultrasound is a useful modality in those kids with cloudy corneas. So in terms of initial management, if you're suspecting a child has congenital glaucoma, they've got a cloudy eye with epiphora and a large looking eye, then really your initial management should be focused on reducing the pressure as quickly as possible for two reasons. One, that helps to arrest the process of ophthalmos, as well as improving corneal clarity, because at the end of the day, you're going to need to perform some definitive type of procedure to address the problem. And ideally, you want a clearer view of the anterior chamber as possible. So in our clinic, we'd start the child on topical agents and either a beta blocker with a carbonic anhydrase inhibitor, along with a prostaglandin agonist, basically throwing everything at the child is very useful as a first line agent. Kids actually tolerate oral acetazolamide very well. And any child with a cloudy cornea, I would automatically start them on oral acetazolamide around about 7 to 10 milligrams per kilo 3 times a day. And that's very good at lowering intraocular pressure quite quickly and improving corneal clouding. At the same time, generally, you want to be arranging for an examination under anesthetic. There's a lot of subtle signs that you're not going to be able to see in the office, particularly in young or newborn babies. And really, they need a very thorough check of the eye to work out what's going on. And the idea is that you would perform the examination under anesthetic with the plan to perform some definitive surgical intervention at the same time. So we'd consent them for an EUA plus usually a goniotomy or trabeculotomy, depending on the view. As with all kids with any eye problem, it's important to always keep in mind refractive error and treating any refraction problems, and also considering amblyopia as well. The examination under anesthetic is probably the most important part of glaucoma assessment. And the goal is to confirm the diagnosis, so your suspicion in the clinic, assess how severe the condition is. We also want a baseline to compare to for future reference. So it's important to get good baseline biometry on the eye so that you know if any further intervention is necessary, or if there's any significant failure in your treatment. And then you want to be then making plans to perform some form of definitive operation under the same anesthetic. So what do I do when I see a kid with for examination under anesthetic? Well, the first thing I want to do is measure intraocular pressure, and it's really important to have a good discussion with your anaesthetist prior to the case starting about your plan on how you're going to measure intraocular pressure. If you plan to measure the intraocular pressure, it should be the very first thing you do, and ideally it's before the child's fully asleep, because we know that a lot of the volatile agents and a lot of the anesthetics itself will artificially lower your intraocular pressure, and you're going to get an artificially low reading. Agents such as ketamine, chlorohydrate can be useful because we know they don't seem to appreciably lower intraocular pressure. However, the airway risks associated with those agents often make some anaesthetists a bit wary of putting kids to sleep based on the ketamine induction. So certainly my center was a bit discouraged from doing that, and it's a bit variable in who I can convince that would be happy to give ketamine. So essentially I've moved to doing intraocular pressure as soon as the child is asleep, before they've been intubated, and I jump in there and get my Perkins tonometer and measure the intraocular pressure there and then. So it's as soon as the child has been induced to sleep, so you're getting the earliest pressure. It's probably still going to reduce the pressure a little bit, but at least you're getting a consistent sort of value. And it's important to do the same thing on the same child each time, so you're getting some consistency. We also look at the refraction of the child, so if they're myopic or not is very important. Then going on to measure axial length, measure corneal thickness. That's important, not necessarily for making any adjustments to the intraocular pressure, but we know thicker corneas are more edematous, and also measuring corneal diameter. And that's important as a baseline, as well as to look for in the future for any evidence of progression. Imaging is really important, and we have RetCam available to us, which we can take good anterior chamber as well as fundus images. You can actually use the RetCam to do good gonioscopy images with higher focus, and also using the gel, a coupling gel as basically like a gonio lens. You can get good images of the angles. And also obviously measuring, looking at the optic nerve. If you're taking photos of the optic nerve, it's a good idea to take it in varying lighting conditions, so you can have consistency when you're looking back, if there's any difference in light that you use, because overexposed images compared to underexposed, often the cupping can look a little bit different. And if you have it available to you, then OCT imaging can be useful as an adjunct, although obviously it's not available to many in the operating room. So essentially, there are lots of conditions as well. Well, there's certain conditions that we need to be aware of that can sometimes look like glaucoma, but aren't necessarily glaucoma, such as conditions that can cause high axial myopia or corneal clouding or ophthalmos. And it's important to be sure that we're dealing with glaucoma before subjecting children to surgery or treatment. And you want to exclude those conditions. There are conditions that have fairly typical features which we know are associated with glaucoma, and we'll go through those conditions now. So the first of those that we should be aware of is the spectrum of anterior segment dysgenesis, of which Axenfeld anomaly would be is part of that. And when we discuss Axenfeld, it's part of a spectrum of conditions, of which Axenfeld-Rieger syndrome is a sort of the encompassing term for a syndromic form of the condition, but it's associated with the anomaly itself is the term we use to describe where you see posterior embryotoxin, which we can see in up to 10-15% of the normal population. But what is different is you have adherent strands of iris coming up and attaching to that anteriorly displaced Schwalbe's line, which is what the posterior embryotoxin is. And when we see that, we know that in itself is a risk factor for developing glaucoma. So you can see on the photo here, you've got a white line in the peripheral cornea, which corresponds to posterior embryotoxin, and iris strands adherent to those. So that's what we call Axenfeld anomaly. Then there's Rieger's anomaly, which may or may not be associated with an Axenfeld anomaly. And that's to do with the iris changes that we see in this condition. And it's classically, you see choroctopia, so a displaced pupil, polychoria, so big holes in the iris that's developed, and they can progress over time, and also iris hypoplasia. And Rieger's anomaly can be associated with other systemic or conditions, including dental changes, craniofacial changes, and redundant umbilical skin. And we call that combination of findings Rieger's syndrome. When that's combined with Axenfeld anomaly, we call that Axenfeld-Rieger syndrome, of which there's multiple genetic causes for Axenfeld-Rieger syndrome. It's an autosomal dominant condition, so there may be a strong family history of children of even parents having eye issues, but it does have variable penetrance. So some parents may not have glaucoma or have relatively mild expression of the condition compared to a more severe phenotype in the child. So it's important to always look at the parents as well. The genes that we see associated with that are the PITX2 gene, the FOXC1 gene, classically, more newly described as the FOXO1A gene, and less commonly we can see sporadic conditions associated with PAX6 and the CYP1B1 mutation that we see in primary congenital glaucoma. The risk of glaucoma in this group is pretty high, so it's about 50% risk of glaucoma, so they need lifelong monitoring for intraocular pressure elevation. These kids often have significant other comorbidities and syndromic features. The craniofacial features are quite striking, so they often have hypotelorism or telecanthus. They have a maxillary hypoplasia with a flattening in the midface. Their forehead's quite prominent, and often they have a quite flat, broad nasal bridge. They have quite significant dental anomalies, so that's a reduced number of teeth, and the size of the teeth are often quite small. And then there's this classic redundant periumbilical skin. So you can have a look at the baby's belly button, and there's often a excess of skin there that you would not normally see. Other described issues have also been in boys, hypospadia, anal stenosis, pituitary abnormalities, growth retardation, and also cardiac anomalies. So any child that you see that has these sort of findings in their eye, they should be seen by a pediatric specialist as well to look for these other comorbidities. Aniridia is another genetic condition that we need to be thinking about in congenital glaucoma. It's an autosomal dominant condition. It's associated with the PAX6 gene, and a third of the cases that we see are sporadic, but there is also variable expressivity in the gene. So again, within the same family, you can get various severities of the degree of aniridia, from very mild aniridia to complete aniridia, which you can see in this picture here, where you have ciliary processes quite readily visible in zonules. Classically, you have a nystagmus, which is due to foveal hypoplasia. Glaucoma is relatively high risk, up to about more than 50% of kids. Classically, kids get an anterior polar cataract as well. Lens zonules are often quite weak, and so lens subluxation can be an issue. We also see limbal stem cell issues, so it's very important to be considering the type of surgery you're doing in these kids. These eyes don't like surgery at all, and so because of the limbal stem cell fragility as well. There's, again, syndromes associated with aniridia, of which Wager syndrome and Gillespie syndrome are the two. Wager's, and I'll just, so this photo just shows that you have a rudimentary iris root. The mechanism for glaucoma in aniridia is twofold. There's probably an element of anterior segment dysgenesis, but also over time, you tend to get a progressive angle closure with the iris root often rotating anteriorly over time and causing adhesion to the trabecular mesh, which then is also caused a secondary cause of glaucoma. The WAGI, or Wager syndrome, is an important condition because it's associated with Wilms tumor, which is obviously a life-threatening condition. And it's a condition, it's a tumor that we should be considering in all kids with aniridia, particularly sporadic. If you've got a kid with a strong family history of aniridia, and it's obviously a dominant condition, then the risk of Wilms tumor is extremely low. But other than that, then these kids need 3 monthly surveillance with renal ultrasound until they're about 7 years of age to rule out Wilms tumor developing. They have other genitourinary issues, and they're often mentally handicapped. Peters anomaly is another condition that can be associated with high association with glaucoma. It's a bit of a mixed bag, and Peters anomaly is just more of an encompassing term to describe a phenotypic expression of a lot of conditions that as part of the anterior segment dysgenesis. And so for that reason, because there's lots of genes implicated, which are also associated with, for example, Axenfeld-Rieger syndrome, there's variable degrees of inheritance, including sporadic and autosomal dominant forms and autosomal recessive forms. They can be associated with microphthalmus, aniridia, sclerocornea, colobomas, abnormal optic nerves. They've also been described in persistent hypoplastic primary vitreous and myopia. Commonly, they're bilateral, and the phenotype you get is a corneal leucoma, or a scar on the cornea with adherent iris to that. And that's type 1 Peters anomaly. Type 2 Peters anomaly is a more severe variant where you get failure of cleavage of the lens from the anterior chamber, and it's attached to the corneal leucoma as well. They invariably have quite poor visual prognosis, and they're very difficult to treat. Rates of glaucoma, again, are quite high, in the order of up to 50 to 70%. Peters anomaly is also quite strongly associated with systemic issues, and so it's important that these kids also get a pediatric workup. About 60% of kids with Peters anomaly have some form of syndromic association. There is a condition called Peters plus syndrome, of which the gene has been recently described, which is the B3GLCT gene, which is a recessive condition, and that's associated with significant neural defects, cardiac anomalies, genitourinary anomalies, as well as some craniofacial issues as well, and they can have hearing issues as well. The the capillary hemangiomas, the port wine stains, can be associated with secondary glaucoma in children, and that can present from birth right through to later on in life. The risk of glaucoma overall in kids with facial capillary hemangiomas, particularly involving the V1 distribution, is around about 10% lifelong, and that's around if the upper lid is involved. One of the phacomatoses associated that's characteristic of the port wine stain on the face is Sturge-Weber syndrome, where you get capillary hemangiomas upon the upper face, as well as also malformations on the upper face involving the trigeminal nerve, as well as on the leptomeninges and the cerebral cortex. For that reason, there's variable rates of glaucoma, but the risk is about 50%. Children can have intellectual issues due to the cranial involvement, and seizures can be a real issue in these kids. And it can be often associated with choroidal hemangioma as well. These kids are really tricky. There's two sort of peaks of rates of glaucoma in these children. Classically, the younger kids are thought to be due to a trabecular dysgenesis. And so for that reason, angle surgery is proposed to be a good way of treating the glaucoma. Later on in life, you get another peak in glaucoma around about 7 to 10 years of age, and that's more to do with raised episcleral venous pressure driving the glaucoma. And doing angle surgery in those kids is not going to work and is associated with a high rate of complication, including intraocular hemorrhage. So it's important to look at these kids carefully to see if there's any evidence of any choroidal hemangioma, particularly in the young kids, because if you do proceed to doing any glaucoma surgery, the rates of intraocular pressure, if you end up with hypotony, intraocular hemorrhage, sorry, if you end up with hypotony, are very high, and they're very difficult eyes to sort of manage. And often these kids do better with a tube, for example, than angle surgery. So they're the known signs that we look for, or conditions that we see associated with glaucoma. What about the conditions that can mimic glaucoma? Well, there's a whole pile of conditions which will cause cloudy corneas in neonates. There's the mnemonic STUMPed, which is as medical students and trainees we learn to try and remember them all. But generally, they can categorize them as traumatic issues. So forceps delivery, or if they've had a previous amniocentesis that's pranged the cornea, you can get corneal clouding. Infectious causes, particularly herpetic disease, rubella, which is less common in our community now with immunization, and more rarely bacterial ulcers, usually from vertical transmission during birth. Obviously, glaucoma, Peter's normally we've talked about. The congenital endothelial dystrophies, of which CHED and posterior polymorphous dystrophy are important considerations. There's also sclerocornea, corneal and limbal dermoids, corneal keloids. We also have to think about the metabolic disease, particularly in bilateral corneal clouding, persistent fetal vasculature, and clefting syndromes. And there's a whole pile of rare syndromes that can be associated with corneal clouding. Forceps trauma is one of those ones that usually there's a history. The things to be looking out for is the pattern of sort of corneal clouding. Sometimes it can be diffuse. Usually with a forceps injury, it's fairly a linear type of injury. It still causes breaks and desmates. There's often a bruise across the baby's face, which makes it pretty obvious. But if that in the absence of the bruise, usually there's a high degree of astigmatism. There's no evidence of any ophthalmos, so the corneal diameter is normal, and it's usually a myopic astigmatism that you see, and it's in the axis of the injury. Congenital hereditary endothelial dystrophy is another sort of differential. That's primarily just a purely endothelial issue. It's a recessive condition, and it's linked to the SLC4A11 gene. And you get epithelial clouding, and it's a thickened endothelium that's not doing the job. And this is not associated with congenital glaucoma. And the important negative findings are that the corneal diameter is normal, and you check the intraocular pressure, it might be a bit raised because the cornea is thick, but it's not significantly raised. Posterior polymorphous dystrophy is a dominant condition. It has a variable way of presenting. It can present with quite diffuse corneal clouding in early life in more severe forms. It's usually asymptomatic. It's a dominant condition, so parents or and relatives should have evidence of this in their eye if you look at them. So it's very important to check parents. It's rarely present there at birth, but it does increase your risk of glaucoma if it's present. It can be associated with other syndromic conditions such as Alport's, as well as keratoconics can be associated with that as well. What about a child with a large eye? Well, certainly large corneas, the most common finding would be congenital glaucoma, although congenital megalocornea or anterior megaloophthalmos is certainly a condition which you need to consider. And there's certain features that would point you in that direction versus considering glaucoma, as well as considering congenital high myopia in long eyes or any other connective tissue diseases that can be associated with myopia. I've had a couple of kids who've been treated as a glaucoma patient who, in fact, had congenital megalocornea. And these kids essentially have quite large corneas. Usually they're significantly larger than average, or around 13 millimeters or bigger. It's typically an X-linked condition, so usually boys are affected by it in the vast majority, about 10% of girls. But it can be sporadically, it can be as a dominant condition or recessive in certain, in rarer cases. Is a gene associated that we know of. The things to be looking out for is the corneas are typically clear. They do have quite deep anterior chambers. Their axial length overall is typically normal. And so that's a good indicator that we're not dealing with glaucoma, where you expect the axial length to be larger. The corneas are overall generally either normal thickness or on the slightly thin side, but have a uniform and normal endothelial cell count. So they're just basically a larger cornea, not a stretched cornea. They typically are normal keratometry or slightly steep. They might have some withdrawal astigmatism, but it's not significant. And they may have some iris changes. And they have some elements of issues where they can develop over time, including pigment dispersion. Glaucoma is a risk longer term in these eyes. So it's obviously important, despite the megalocornea. They may develop glaucoma later on, and there's a whole pile again of syndromic associations with it. So it's important to keep in mind the kids who may not be completely normal elsewhere, they need a proper pediatric or genetics workup. So they're the important considerations for differentials of congenital glaucoma. So what do we typically do? So you've got a child who's got, you've confirmed they have glaucoma, they've got high intraocular pressure. So what's the next step? Well, in a primary congenital glaucoma case, it's generally surgery. So we know that 95% of patients would undergo some form of operation to treat the glaucoma. It's not a medical condition. Eye drops and medication aren't going to treat it satisfactorily. And the definitive surgery in the vast majority, in sort of 85 plus, is angle surgery, either with goniotomy or trabeculotomy. If that's not possible for various reasons, you can't access the angle or the angle anatomy is not normal, then some kids end up needing a trabeculectomy. Combined trabeculectomy and trabeculotomy has also been described as done less commonly, and rarely drainage implants would be used as a primary procedure in primary glaucoma. Secondary glaucoma is a different bag. It's a very mixed bag of eyes as well, and so for that reason, there's various different surgeries that have been described, including trabeculectomy, cyclodiode therapy, repeat goniotomies, trabeculotomies. Glaucoma drainage devices are much more common in secondary glaucomas, particularly those after cataract surgery, where other treatments tend to fail. And medications can be used in a significant proportion of kids to tide them over as well. It's important to realize that at least 50% of kids that have surgery will need a second operation during their childhood. So when you're doing an operation, you've got to be planning for the next one as well. So the goniotomy was described in 1936 by Otto Barken, hence the Barken's membrane. And that's probably the first minimally invasive glaucoma surgery that was described. And it's an elegant and simple operation that's extremely effective, and certainly in primary congenital glaucoma, where 80 to 90% of kids can have their pressure well controlled for the medium to long term from the one operation. Conceptually, it's not too hard. You're basically creating an incision across the abnormal trabecular meshwork directly into Schlemm's canal to create a direct communication between the anterior chamber and the collector channels. It's done at the time of the examination under anesthetic with a small side wound, and you can use a specially designed goniotomy blade, or you can even use a 23 gauge needle, which is what I do. So I'll just show you a video of goniotomy. This one I performed as a fellow, so it's a bit shaky, but just to show you through the steps. The most important part of goniotomy is getting good visualization of the angle. This picture shows quite a clear cornea, which is ideal. You need a clear view to be able to do it. You can't really do it blind, so the cornea needs to be clear. Otherwise, you need to be thinking about trabeculotomy. It's very important to get a clear view of the cornea with the portable slit lamp before you go ahead with the goniotomy itself, because that's the best view you're going to get. Even the view under the actual operating microscope is never as good as what you can get with a portable slit lamp, so you need to make sure that you can visualize the angle and use a little Cope lens, which is a direct view in gonioscopy, to get a feel of the landmarks before you then proceed with the goniotomy. And then you perform the goniotomy. So this is just having a look at the angle, making sure I'm happy that where the trabecular meshwork is. Then once we're happy, then making I make a partial thickness corneal incision just at the limbus, nuclear cornea, not all the way through, just creates a little tract for the 23 gauge needle, which I've mounted on a ProVisc or any cohesive viscoelastic. Just reach across to the trabecular meshwork and then cut through. It cuts like butter. If you get any resistance, you're in the sclera and you need to pull back. And you can see the iris starting to fall back quite nicely as the cleft is formed. It doesn't take very long, it takes 2 minutes, and then you can see as the pressure reduces, you get quite nice blood reflux through from the collector channels, and that's the procedure. Now, that's done without any viscoelastic in the eye. You try to maintain the anterior chamber, and if you can avoid putting viscoelastic, that's often better. And then you just suture the wound up and reform the anterior chamber with some BSS. So it's fairly simple in execution, but most of the complexity is making sure that you're in the right spot. A trabeculotomy we perform in cases where the angle is not so visible through the cornea, so in clouded corneas, or you can do it as a primary procedure if it's your procedure of preference. And it's typically done as an ab externo approach, although it can be done ab internally with other devices. We use a trabeculotome, which is this device here, which has a two-pronged curved blunt instrument. One goes into Schlemm's canal, and the other shows you where you are, basically, and then you rotate that into the anterior chamber, ripping open the trabecular meshwork. So I typically perform trabeculotomies using a temporal wound. I don't want to touch the superior conjunctiva. Again, thinking about what the next operation is going to be, I prefer to leave the superior conjunctiva alone. And so for that reason, I don't do combined trabeculectomy, trabeculotomy. So make a little scleral flap, and now I'll just pause. So you can see here, Schlemm's canal is where the white of the sclera and the blue of the cornea kind of meet. You can see the radially oriented scleral fibers as well. It's difficult to make out in the video. You can also see here a little collector channel sort of bleeding through there. So we know we're kind of in the right spot, and you make an incision over the top, just carefully, not too deep. You don't want to go into the anterior chamber. What I'm looking for is an egress of either aqueous, or it's starting to show that here with the blood coming through, and there we go. You can see blood coming through Schlemm's canal. Then you put your trabeculotomy in and then rotate that into the anterior chamber. We'll do the same on the other side. Again, coming through Schlemm's canal. Again, you should get no resistance, and then rotating it nicely into the anterior chamber. And that's it. Then you close up your wound. Ooh, okay. So we have other devices available to us now, and has been described proline assisted 360-degree trabeculotomies. I prefer to use an illuminated microcatheter. You can do this as an Abbott-Turner approach to avoiding touching the conjunctiva, which is a nice advantage if you've got a clear cornea. And this is threaded through Schlemm's canal internally through a small goniotomy. So I'll just show you the technique there. This is like one of the second one, I think. So it's a little bit cumbersome. But yeah, you've got an illuminated microcatheter, so you know exactly where it is. And then we thread it through the eye. You can see it going through Schlemm's canal as it's coming through. The advantage of that is you know it's in Schlemm's canal. If it's not illuminated, you don't know where it's going until it doesn't come back. And there's been cases of scars underneath foveas as it's gone into the suprachoroidal space. So you keep advancing it until it comes out the other end. And unfortunately, my video cut off. So you know it's all the way through. And once it comes through, you grab the other end and basically garrot the trabecular meshwork for 360 degrees. So there's a significant advantage to doing it that way in that you get 360 degrees of trabecular meshwork treated in one operation. You don't have to go back and do a second operation. So what do we do if we've had a failed primary surgery? Well, you can repeat the trabeculotomy or goniotomy in a different area to get more real estate. Or if that's not possible, or it was failed because you couldn't get proper anatomy, then you can consider a trabeculectomy. Or if you've had failed secondary surgery, then what do we do? We'll consider a trabeculectomy. A lot of us would go to a glaucoma drainage device or considering diode laser. Trabeculectomies have had a bit of a variable outcome in pediatric glaucoma, and there's a lot of people who would advocate for a combined trabeculectomy with trabeculotomy, and that's done in a lot of centers as a combined procedure. It's a bit variable in terms of the outcomes, and it really depends on the center's experience with trabeculectomy. And certainly there's places that have reported very poor outcomes, and that's generally on people who are not actually that familiar with doing them in kids. The anatomy in kids is very distorted, particularly in ophthalmic eyes. The surgery itself is more challenging. You've got thin sclera. You're often quite posterior. If you're doing it at the same time as trabeculotomy, you're often quite posterior compared to would be with the standard trabeculectomy. So there's more risk of iris or ciliary body incarceration and vitreous incarceration as well, making the trabeculectomy more likely to fail. Often kids are more obviously prone to fibrosis, and so we often augment them with mitomycin, but that comes with its long-term risks of bleb-related complications, including a higher rate of endophthalmitis in some series, up to 10%. Kids often need a bit more management as well, so you can't really go and do suture lysis or do some bleb needling. These kids need to be under an EUA to do any of that as well, so you've got to be thinking about the more need for anesthesia. And again, you've got to be thinking about future conjunctiva as well. So I don't tend to do combined trabeculectomies for that reason. If you look at a lot of series, the rates of success with a trabeculotomy alone compared with a combined trabeculectomy tend to be fairly similar. Glaucoma drainage devices come with the whole risk of issues in kids with growing eyes with tubes in them for a long time. You can get tube erosion or migration. Strabismus can be an issue, which in young kids is an issue in terms of amblyopia. They often get quite scarred. I used to put the center I was in Toronto, we used to use Ahmed valve devices in children. They universally failed after a year or two, just a massive scarring, which you can see in this little video. And corneal issues are obviously a quite significant issue with long-term use of tubes. So often it's the last line of defense, particularly in some of the more severe glaucomas. But they don't come without their joys in terms of lifetime management. So that's glaucoma in a nutshell. It's a lot to cover in just over an hour. So if anyone has any questions, I'd be happy to take them now. And I'll stop sharing the screen.
Thank you, Dr. Anthony. I think it's very comprehensive lecture. Yeah, I understand that you we have a lecture from A to Z. I think, yeah. All
Yeah.
I think, yeah, it's quite very very clear. I think, yeah. And then we have it's quite a lot of very challenging glaucoma cases, childhood glaucoma cases. We found if we deal with that cases. So I just want to see if there is a question here, since it's almost time actually. So I'll choose two questions from the chat box here. So so there is a question here for Dr. Anthony. Thanks, yeah.
Yeah. So I've got
yeah from Buhana Mawarati. Yeah, thank you, Prof. Anthony. What is beautiful lecture. I'm Buhana, and then second year of resident. Would like to ask a few questions. What would you be the indication for the surgery in pediatric glaucoma, and what should be performed instantly? Is there a golden period or parameter that need to be looked out for? And then the second, among cases of pediatric glaucoma are mostly syndromic association disease. Would there be any type of condition where certain anti-glaucoma medication are permitted?
Okay. So I'll just answer that first one. So you're not going to perform any operation instantly, but certainly angle surgery is the definitive operation if you have access to the angles. So in terms of surgery, that would be a goniotomy or trabeculotomy. And in terms of golden period, I'm not quite sure what she means by that, but basically, if you have a high index of suspicion that this and it fits with congenital glaucoma, you want to get the cornea clear, and that's with medical management initially, and then plan for a definitive operation with the time if you're confirming the diagnosis with an EUA. So you're looking for signs of any that confirm your suspicions of primary congenital glaucoma, in which case, angle surgery will work quite well. And then gonioscopy is really important in these kids to look for signs of angle dysgenesis. For example, Axenfeld-Rieger type anomaly, which might mean your angle surgery is less likely to be useful. Sometimes they don't even have a scleral, a Schlemm's canal that's easy to cannulate. In terms of anti-glaucoma medications that are prohibited, we always avoid alpha agonists in children, and particularly in kids with CNS issues. They're much more sensitive to the alpha agonists in terms of CNS depression. So never give bromidine to children. Aproclonidine can be used, but you still have to be careful. So that's iopidine. And you want to use the lowest dose that's going to be effective as well. But generally, as a rule, you want to avoid alpha agonists in pediatric glaucoma. Carbonic anhydrase inhibitors, beta blockers, as long as you're using a lower dose, are generally pretty safe.
Yeah. For brimonidine, I think what age the youngest that you avoided to give?
Look, depends on the size of the child, but certainly below 12, you need to be careful. I've given big kids above 6 or 7, you can give it. They don't tend to get CNS depression with sort of respiratory arrest, but kids can be a bit more likely to be sleepy. So parents might report that their kids are more sleepy than usually on alpha-GAN, in which case you'd stop it. They don't tend to get that so much with iopidine. So that's another option you can use. So that's aproclonidine.
Okay, thank you, Dr. Anthony. So we proceed to the second question from Dr. Putri Rahman. Yeah, I think I would like to ask in the patients, yeah, and with the primary congenital glaucoma in AO, it is said that the younger of age of the diagnosis of the glaucoma, the prognosis in this patient can be worse. And then there are several surgical options that can do choose, yeah. And then there is a best option that can be done for primary congenital glaucoma. There is the neonatal onset of the newborn, and is there a golden time for the surgery? And continuing the doctor thinks, I think that similar to the first question, I think.
Yeah, basically angle surgery, so goniotomy or trabeculotomy if you can, as soon as possible.
Yeah.
So there's no golden times now. As soon as you make the diagnosis.
Okay, you move on to the Dr. Dianisa. So see that there is a questions for finding glaucoma in the clinic. So is there ancillary examination that you recommend to do in order to diagnose toward the secondary glaucoma? What particular blood tests or systemic evaluations need to be
so there's no real blood tests you can do. I mean, you can do genetic testing. That's very costly and time. It takes a lot of time for that to come back. But there's no particular genetic blood test that you can do to look for secondary glaucoma. It's purely a clinical diagnosis, and gonioscopy is your best bet at helping to diagnose that and looking for those signs we discussed in terms of looking for evidence of aniridia, Axenfeld-Rieger, ankle segment dysgenesis, having high index of suspicion in kids who are not quite normal in terms of development or may have any other issues going on. So most kids with unusual with bilateral disease, you'd be sending to the pediatrician and geneticist for a full systemic evaluation as well.
Yeah, I think I agree. For from the Triana, so with the Sugar-Weber syndrome, so what do you choose for a diagnosis for the surgery instead of trabeculectomy or GDD implantation, or maybe others? Maybe surgery that you suggest, since there will be a lot of complication after the surgeries. They have
these are kids that are tricky to manage, and it depends on the time that they develop their glaucoma. So as I was saying, there's an element of angle segment dysgenesis that may be contributing to their glaucoma in the early period. So these are kids that often develop with high pressure in the first couple of years of life. They don't have any evidence of raised episcleral venous pressure yet. So you're not seeing a lot of blood in Schlemm's canal, for example, and there's no capillary hemangioma. In those kids, they can do well with just angle surgery, so goniotomy, trabeculotomy. In those kids where episcleral venous pressure is the driving cause, and that's usually in kids who develop raised pressure later on in life, so around peak age of 7 to 10. If you can't do angle surgery in those kids, they'll get a big intraocular hemorrhage. And you won't have fun with that. And so you really have to either be considering a trabeculectomy, where you have to be very careful and that you avoid hypotony in those cases, or a glaucoma drainage device. And probably a glaucoma drainage device in my hands is my preferred option for these kids, because it's just a bit safer in terms of avoiding significant hypotony.
Yeah, so from doctors, how about the laser diode from Dr. Egi?
Look, I'll use that if the tube's failed.
Okay, you also use for laser diode to this patient for the Sugar-Weber syndrome as well?
Not as a primary procedure.
It's not the primary. I think after you do the trabeculectomy and or maybe the GDD.
Yeah.
Okay, so I think this is the last questions that might be, what will be the cause of the failure of surgery in this case?
Sorry.
For the glaucoma, in the childhood glaucoma, that will be, there is a lot of reasoning there is a failure of the surgery for this kind of children's things, because there's a lot of different cases in childhood glaucoma. So, and then different kind of surgery that you choose, that you also mentioned it's about 50% that might have a second surgery. So,
that's right.
And then maybe this is the questions of what the cause of the failure in the surgery in this case.
The failure is, certainly in angle surgery, you get the cleft can close up with iris incarcerating into the cleft. Basically the drainage pathways can deteriorate over time, so the aqueous collector channels just stop working as well over time. Would probably be the most common reasons.
Yeah. I think the question is for Dr. Amani. I think
oh, I see. Sorry.
Yeah, I'm sorry. Yeah, this is my fault. Sorry, Dr. Anthony. You can answer the questions, Dr. Amani.
Thank you, Prof. Ike and Dr. Anthony. Thank you for Dr. Salim for the question. So Dr. Salim asked that the IOP in this patient keep rising even after the first surgery, and what is the possible mechanism that may cause this the failure? So I think various factors may results in surgery failure based on what I've read. Maybe the age during the surgery, and she has neglected for around 8 months from the initial complaints without bad compliance, poor compliance on the topical medication, and also maybe this may result in surgery failure, Prof.
Yeah, okay. Yeah, I think it's very challenging to do the surgery and then to manage the childhood glaucoma. And usually in my clinic, to manage the childhood glaucoma usually is managed by the pediatrician pediatrician eye specialist, not in the glaucoma specialist. But if they need to do the glaucoma drainage implant, so they will refer it to us things. But I don't know in birth, Dr. Anthony, do you have the same policy, or do you just write?
But no, that's right. So it's a pediatric person that does the glaucoma surgery primarily, and then if they need tubes. But I'm the both.
Oh, you but
yeah,
of course. So you have a lot of experience of doing that. So I think that's all. I think we over time things. I give it Dr. Mita. I think almost time. I think because time.
Yes, thank you, Prof. Thank you for closing up and bring this session. So it's become a very interesting session. So before we end up this session, as usual, please we can take the photo for the professor and doctor who willing to open the cam.
Yeah. I would like to thank Dr. Anthony. Thank you very much for lecture. It's very interesting, very good, and Dr. Amani as well.
Dr. Miki, can you help us and count?
Sure, Dr. Mita. I would like to invite everyone to open your camera, please, as we will
recording stopped.
Photo session. Okay, so I'm going to start taking a picture now. Everyone give us your best. 1, 1, 2, 3. Third page, 1, 2, 3. Fourth page, 1, 2, 3. Fifth page, 1, 2, 3. And that will be the last one. I'll give it back to you, Dr. Mita.
Thank you, Dr. Miki.
Yeah, I saw Prof. Morgan. Hi, Prof. Morgan. It's nice to see you.
Hello.
Yeah. Thank you. Thank you for the lecture. It's very excellent. Bye.
It was very good.
Bye.
Great session. The case was excellent as well. Very nice case.
It's very nice. Yeah.
Thanks very much.
Thank you very much. Thank you all the doctors.
Thank you, everyone.
And then,
Bye.
thank you everyone. Bye.
Thank you, Prof. Doctors.
I leave.